Helicopters and ambulances are regular arrivals 24 hours a day, 7 days a week at the Prairie Heart Institute at St. John's, one of the largest heart centers in the Midwest. Patients within a 70-mile radius of Springfield who are having a heart attack or other cardiac emergency frequently choose this hospital's Stat Heart program for treatment. Dr. Greg Mischel, for many of us, that first heart event is going to be a heart attack, and it's the day. It's the day that we're really afraid of.
Right.
You know, we could be one of those people being wheeled into the cath lab in an emergency situation. It's scary for a lot of people.
Right. Well, and the way we broach it is that the worst day of your life is an opportunity for us to prove it's the best day of our lives, because that's what we train for, and it's the first heart attack you've had, but it's not our first rodeo. And so literally we've done this hundreds, frankly thousands of times. On an annual basis, we treat about 200 acute heart attacks, patients being rushed into the catheterization laboratory. About 150 times a year they're being flown in from outside communities, and about 50 to 60 times a year they're actually having walked into our ER, or better yet, driven into our ER and coming up directly to the catheterization laboratory. And we've practiced and rehearsed this, and then literally through a decade or more of doing this, it's a fine science now. And we track every minute of that process to see how we can further refine it.
I remember when I was growing up, and you probably had the same experience, many of my friends' fathers would have heart attacks in their 40s and early 50s, and they would die.
Right.
You know, that was it. And you go, oh, they died so young. Well, they did, and it was this heart attack.
Right.
That's not happening as often anymore.
No. And what we're seeing more often now is older people presenting with heart attacks, and more women presenting with heart attacks, I think. And that reflects two trends. One is the aging, three trends really. The aging population. Number two, an increased emphasis in community and public health being placed on addressing women's health, and oftentimes how they present differently than men. And then thirdly, public health has emphasized the importance of smoking cessation, blood pressure checks, early and cholesterol control. And so you're right, we don't see as many young people, although you would be surprised we still have patients in their late 20s and early 30s who present with a heart attack, and those are bad. But the difference nowadays is when you present with a heart attack as your first manifestation of heart disease, one of the most interesting statistics is that, in fact, you're not likely to die of either the acute heart attack, that's changed, nor are you likely to die from heart disease in the future. You're more likely to die of another cause, meaning that once we've identified you as having a heart attack, we're much more successful in saving your life. In fact, the chance of any one person dying within 30 days of a heart attack is less than 5% now. And once we've identified you with heart disease, the medications that we put people on are so good that oftentimes they don't have another fatal or another cardiovascular event, certainly a fatal cardiovascular event, and they live to die, if that's the appropriate term, they live to die of another cause.
A man with heart attack symptoms has arrived by ambulance. The system is set up to expedite treatment by taking him directly to the cath lab. Dr. Roberto Pacheco is there to meet him.
Hi, I'm Dr. Pacheco. I'm the cardiologist. How are you feeling?
I've been better.
Are you having any chest pain right now? How bad is it?
Well, all my pain together is about an 8.
Where else is it hurting?
My neck and back.
Okay, what time did the pain start?
I don't know, somewhere probably around 9 or 10.
Have you ever had pain like this before?
I have somewhere.
Any heart problems before?
19.
I've got pulmonary embolism.
Okay. Was the pain similar to this last time? What were you doing when the pain started? Today? Yeah. Okay, is it sharp, dull, pressure, burning?
Sharp and dull. And it hurts like it's still on my chest for my chest.
Does it hurt when you take a deep breath?
About the same time, 71-year-old Sandra Smith of Assumption is also having heart attack symptoms and is being taken directly to the cath lab, where Dr. Shailesh Nandish will have a look around inside her coronary arteries. The procedure is called an angiogram, and it will help Dr. Nandish determine if she has blocked arteries and how severe the blockages might be.
This lady came in with chest pain, which started out early this morning. Got better, but again got worse again. She went to Haina Community Hospital where they did an EKG and found out she was having what we call as an acute MI, which is a heart attack. She was started on all the appropriate medications by protocol, and she was emergently transferred so that we can open up the artery. So now we took a look at the pictures, and then looks like one of the arteries called the left anterior descending coronary arteries, which supplies most of the heart muscle in the front of the heart. That appears to have a 99% blockage with decreased blood flow. So she also has the right side, which is also already blocked, and looks like it's been blocked for some time. So we're going to treat this one first, and then take a look at the other one, see if that needs to be treated as well today. More than likely, we may be able to get by with treating this one now and bring it back for the other one later. So now we'll put the wire across and across the blockage. We'll open it up with the balloon. Now we'll go ahead and place a stent, and hopefully that'll take care of the immediate issue.
Stent's going in.
The stent, when inflated inside the artery with the help of a balloon, opens the blocked artery, increases blood flow, and in this case helped Sandra Smith emerge from what could have been a disastrous night. The key to the Stat Heart program and the chest pain network here is to get the patients, mostly from outlying areas, to the cath lab as soon as possible.
When they get to St. John's, what happens is they come down this helipad, and we know already that they're coming, so what we do is we take them right from here, right to the cath lab. It's such an efficient process that it really saves heart muscle. It's really the choice of the hospital that's sending the patient how they come, and if weather's bad, they can come by ground, but we really prefer them to come by air because they're so far away, and it's such a great way to get patients here. There's a nurse and a paramedic on board. Patient gets very good care. Our doctors are ready for them when they get here.
Why is it critical for them to get there as soon as possible?
It's critical because, for a couple of reasons. The big reason is they've got an artery that's either 100% blocked and causing what we call an ST elevation MI. And it's crucial to get that vessel opened in a timely manner. Otherwise, heart muscle begins dying, and that part of the heart is never comes back. So for the patient, it's mortality and it's long-term benefits for getting that vessel open in a timely manner.
I want to show a graph here because this is interesting. I didn't know this. This is an EKG, right?
This is a 12-lead EKG.
Okay, and let's look at the middle bar, for instance. Just look at this middle bar. When we get to here, you call this the STEMI. What does STEMI stand for?
It's ST elevation MI, and we're seeing that displayed on this EKG with this, what we call a tombstone. That means the patient's artery is actively infarcting. They are not getting blood flow to this part of the heart, demonstrated here on the EKG.
Okay. So when you see this, you know this is a heart attack. It always looks like this.
Correct.
Wow.
9 times out of 10, yes. This is what sometimes you won't see as big of an inflection, but this is definitely, this patient is having an ST elevation MI, which is determined by the ED physician.
Okay. Now you stay here at the hospital. This is where the program is, but you serve a big area, and some of these people that live out in the outlying areas, they go to a small hospital, for instance.
Correct.
And they may have access to a helicopter to get them here. They may have access to a ground ambulance to get them here. But that's all coordinated, isn't it?
Correct.
Through your program.
Yeah, we have 2 RNs who are on call 24/7 for this program. We switch weeks, but there's always a what we call STEMI coordinator or stat heart nurse who's on call 24/7 for this program.
Yeah, and then you actually do training as well, because the ambulance drivers and the attendants and the people that are flying in the helicopters, they all need to know how the service works.
Correct. So we go out and provide not only hospital to the ED physicians, the ED nurses, but also the EMS system as well. It's a very team approach program, which means we need everybody in the team to know what their part is. So we individualize training for each part and we all come together as a team to get that patient onto the PCI hospital in Springfield for rapid treatment. So.
And you might have 1, 2, 3 a day, maybe 4 a day.
Yeah.
It's pretty busy.
Yeah, some days are quiet. We might only have one, we might have none, and then there might be a day we have 3 or 4, and it can be pretty intense. But we're doing our job, and we're getting those patients who otherwise wouldn't have had this availability prior to the program, and we're providing a service that gets them treated just as if they were having a heart attack in a big city.
But Sandra Smith was not having a heart attack in a big city. She was having a heart attack in tiny Assumption, Illinois. We'll check in on her soon, after she's had a night of rest. One of the first patients we met this week was 82-year-old Mabel Canute of Frederick, who came in by ambulance because she was feeling dizzy and lightheaded, and her pulse rate was too low.
I was feeling dizzy, lightheaded, and so I sat there for a little while, and I thought, well, we'll just see, maybe it'll go away. And the next time I checked it, it was 39.
Yeah.
And that told me I needed to get some help, and my doctor told me that I needed a pacemaker. Well, it was set up for Thursday, but I just jumped the gun a little.
Yeah, well, you were right to be alarmed, because when your pulse rate goes down that fast, you were right, weren't you, to get some help?
I was right,
Yeah.
and the ambulance came 80 miles an hour to get here because I had 3 spells in the ambulance. So I needed to get some help, and I knew that St. John's was the best place to go to get your heart fixed. So that's what they're going to do.
Well, Mabel, we are going to wish you the best, and we're going to talk to you after you've had your pacemaker and see how you're feeling. I hope your dizziness and your lightheadedness, all that goes away.
Yeah, they say it will all. It will. My doctor told me that when I got through with this and recovered, got over the healing part, that I would be a frisky filly just like I used to be.
Dr. Ziad Issa, a cardiologist who specializes in the electrical elements of the heart, explains how he plans to remedy her slow heart rate.
Well, hello again. How are you?
Hi, I'm fine.
Doing well. Feeling well? How are you feeling?
I'm dizzy and I have
Still
a
dizzy?
headache.
Okay. Let me explain to you one more time what we're gonna do.
Okay.
Now, the heartbeat starts by an electrical signal generated by the natural pacemaker of the heart that we're all born with. That signal has to go through an electrical cable in the heart and reach the pumping chamber to trigger them to beat. That electrical cable is sick in your case, and it's not really conducting every signal. It's missing every other heart signal, and that's why the heartbeat will be half of the normal. Your heart has been beating 30 and 40 a minute. When the heart beating at slow rate, it will cause the heart to pump less blood to your brain and lungs, so we get short of breath and tired and dizzy, like what your symptoms. So what we're gonna do today is we're gonna put a pacemaker, and the pacemaker is something like this. That comes in the shoulder, below the collarbone, under skin. We make a 1-inch incision, then we make a pocket under skin, and we slip this under skin.
Oh, amazing.
And then we spread 2 wires to the heart. We use the blood vessel that carries the blood from the arm to the heart as our tunnel, where we get the wires into the heart. And that pacemaker will keep an eye on your heartbeat, beat by beat. And whenever your heart rate drops below 60 beats a minute, say, we program it to give the heart a pulse to beat. And we program it to keep your heart between 60 and 120 beats a minute, depends on your activity.
Keep hitting, all right.
Yeah.
Right.
This procedure takes about 30 minutes to do. You stay with us overnight, you get intravenous antibiotics, and tomorrow we'll get a chest x-ray. If things are good, you go
Make sure
home.
it's okay.
Dr. Issa is one of several electrophysiologists here, and the cath lab they work in is somewhat different than the others.
Electrophysiology
Yes.
Lab 4.
Right. So this would be the electrical lab, and you can see there's a lot of electrical.
Wow.
Yeah, there's a lot of electrical equipment in the lab here. Some of which is not particularly familiar to me because I'm a plumber, not an electrician. But we're waiting for a patient to come in. It'll typically be set up individually for each particular case. This is all the equipment that's
Oh, it's
piled-
remarkable.
Yes.
It is absolutely remarkable. And for people who have never been in one of these, they might think that this looks like an operating room, but it's totally different than an operating room, isn't it?
Right.
A cath lab is totally different.
And what you're looking at, so in the far corner there is an anesthesia machine, because many of these patients are actually put to sleep for an extended period of time. Here we have a machine where all the various catheters that measure the electrical currents in the heart are hooked up. And actually, sitting on the table there, you can see the cables that would be put on the patient's chest to measure the various EKGs.
The electrician's tools.
The electrician's tools, right. And then, of course, this is the fluoroscopy, which allows you to visualize the catheters up in the heart.
And 9 labs similar to this, not all set up for electrophysiology.
Right.
but
So
9 of them.
So we have a lab
Wow.
for electrophysiology. We have actually one lab that we do stroke interventions on. We have 2 labs where we do structural heart and peripheral vascular disease, and then coronary labs where we do the coronary work.
Soon, we'll look in on Mabel's pacemaker procedure. First, Sandra Smith is feeling much better after a night of rest.
Morning.
Good morning, doctor.
How are you doing?
I've been terrific.
Good. Feeling better?
Yes.
Good.
So much better.
Good, good.
All that tightness is gone.
Good,
and
good. Any more chest pain or pressure or discomfort at all?
Actually, no chest pain or pressure. It was just like a little. Last night I couldn't rest.
Okay,
A little fast.
okay. Your heart rate was a little faster?
Yeah, I thought
Okay.
it was.
Okay,
But then it would go away.
okay.
But then it'd come back.
All right. Well,
But now it's less and less.
good. But so far everything's looking good. Your blood
Yes.
pressure's good, your heart rate's much better.
Hmm.
I think you're doing very well. So,
Well, I'm a very strong person.
good, good, good.
Yeah.
I'm glad you're feeling better, and I'm glad
Yeah.
you're, feel that way.
Good attitude, and that helps a lot.
Good. So the plan's going to be to get you up and walk you a little more today
Okay,
and see how you feel.
that's a good thing to do.
Right. We'll talk about what you need to do in terms of how you'll take care of yourself from now on.
Mm-hmm.
Okay, in terms of watching your diet,
I'm
increasing
sure there'll be some
activity.
changes, but we can do that.
Exactly, absolutely. And if you're doing well, tomorrow we can let you go home.
Yeah, Dad called and said, when's you being
Right,
released?
right.
I said, I have to talk to the doctor first and see how things go too.
Right. No, I think so far everything's looking good. I'll keep you on some fluids today, and then tomorrow hopefully I can get you home. Okay?
I had a little trouble eating last night. I couldn't eat very well.
Okay.
It just didn't taste right, and I wanted to.
Sure.
I feel like I wanted to throw
Yeah,
up.
sometimes.
But that's normal, I think.
Right. Sometimes after you've taken those pills, which is a blood thinner, it can
Yeah.
irritate your stomach a little bit.
Oh, I wanted to ask you about the pills too,
Mhm.
doctor. Would I have any for you to send home till I can get?
Oh yeah. I think we can Burlington.
Enough to
Yeah.
get me by, because the pharmacy will be closed by 6 tomorrow night.
Oh, no.
Right. No, Tracy will arrange for it. Make sure we have
And
all
then
the
next week
medicine.
in Pena, I can get the medicine.
We'll get you enough for a month, and then we'll go from
Oh, that's wonderful, thank you.
there. Okay.
Thank you.
Let me take a listen to you. Okay?
Sure. And the echogram come out good?
What's that?
The
The echo?
echogram?
I haven't had a chance to look at it
Okay.
yet, but I'm gonna go look at it.
And you could, yesterday, I know you got pretty groggy in the late afternoon, it was period, but I was only giving you 2 terminals, you are also able to just get
Good. So, there is no doubt the heart muscle has gotten a little weaker because of
Yes.
what has happened.
Right,
There's also another artery which has got a 100% blockage other than the one we fixed yesterday.
mhm,
We'll probably do a stress test as an outpatient, and if that shows a lot of decreased blood flow in that area, we may have you come back and do another procedure to open up that 100% blockage. Okay.
Is it like on the other side?
Well, it's on the other side, but your body has already made connections.
Nah,
The artery we worked on yesterday has already made its own connections to supply that blockage.
mhm,
So even if you don't do anything, you'll still do fine. But I
Mhm.
think if there's a lot of decreased blood flow in that area based on a stress test result, you will benefit by having that artery open up. Okay?
so,
So let's get you on good medicine, get you home,
Yeah.
We'll do a stress test in maybe 3 or 4 weeks from now, and then we'll decide if we need to do anything about it.
While Sandra's heart attack was very real, some patients with similar symptoms aren't having a heart attack at all. 28-year-old Eric Irwin thought he was having a heart attack and came in by ambulance last night from Vandalia.
Started out feeling kind of like heartburn, but then it just gradually got worse. It felt like somebody was just squeezing on the inside of my chest. And the red flag for me was when my left arm just got real heavy. I just couldn't lift it. And I have history of heart issues and stuff on both sides of my family, so I was pretty well set up to fail from the start.
Had you had a heart attack before?
No, sir. And luckily this time I still didn't have one. It's more of the way they described it, kind of like a viral thing, just inflammation around my heart. So all my arteries checked out good. So I just, a few days of rest.
So you're feeling pretty good right now.
It's a weight lifted off of me, that's for sure. It scared me pretty good. Scared
Had you
my
ever
dad.
had this experience before?
No, the closest thing to it I've had was I had a case of pleurisy once, a couple years ago, and that didn't feel very good either.
You had these tests done here at Prairie Heart Institute this morning. What were the results of those tests?
Everything came back good.
Good.
So I'm happy. I know my dad will be ecstatic. He's more frightened for me than I was, I think. So, but I can't blame him. I'm his baby boy.
Well, fortunately, Mr. Irvin didn't have any severe coronary artery disease. His symptoms and abnormalities we saw in his EKG and blood work were likely related to inflammation of the heart muscle or lining of the heart. And so he did not require any stenting procedures.
Oh, he was a lucky man then, wasn't he?
He was, yeah. That was very good news for him.
No heart attack, no major blockages.
That's correct.
What can you offer him? Is there medication for his situation?
Well, the treatment for myocarditis or pericarditis, which is likely what he had, is anti-inflammatories and medications to help the heart recover in cases where there is decreased ejection fraction or pumping function of the heart.
So he can likely go back to his normal life, just take some meds until that's gone, and he can go back to living a normal life. Huh?
That's correct. Hopefully he won't have any permanent consequences from this.
Thank you.
Meanwhile, Mabel Canute is in the cath lab resting comfortably during her pacemaker procedure.
Now that's the pacemaker lead. This end, this tip will be in the heart, fixed to the heart, and this end will connect it to the pacemaker generator. That's how the pacemaker will sense the heartbeat and will give the signal to the heart through this lead. So introduce the lead through the vein into the heart, and under X-ray we direct it where we want it to go. This spinner helps extend the screw from the tip of the lead into the right bottom chamber of the heart, the right ventricle. That helps the lead stay in place without dislodging. So that's one lead in. We're going to put the second one. Put one in the right bottom chamber of the heart, the right ventricle, and this second one going to go to the right top chamber of the heart, the right atrium. This is the pacemaker generator. This has the brain and the computer circuits that will control the heart rhythm, but it will sense and control the heartbeat through delivering signals through these leads. And that's where we connect them to the pacemaker generator and secure them in place. One lead for each chamber. One for the right atrium, right top chamber, and one for the right ventricle, the right bottom chamber of the heart. So now they are secured. We wrap them around and bury them in the pocket under the skin, in the subcutaneous tissue.
Mabel's procedure was routine. After a good night of rest, her heartbeat was strong and steady, and she was ready to go home.
Well, Mabel, we had an opportunity we visit with you before your procedure, and we got an opportunity to watch your procedure, and the doctor actually talked us through the procedure while it was going. You would have found it very interesting.
I would have loved to have been able to watch that. You know, or been.
You would have
Yeah.
found it very, and you'd be glad to know it all went very smoothly and quickly as well. It sounds like your procedure just went just about as flawlessly as it can go, so you should be good to go for a while longer.
Well, that's fine. Well, I said I got another 20 years, I'm sure.
Another 20 for sure, huh?
Yeah.
Okay. Well, I'd like to know your secret, because I'd like to know I got another 20. Well, congratulations, and I'm glad you get to go home today.
Yes, sir.
Are you looking forward to that?
Yes, I am. I'm going to stay with my sister for a week till I get back on my feet. But
Yeah.
that's going to be a vacation that I
That's
haven't
right. She
had
can
for
take
a
care
long
of you
time.
for a while, huh?
Yeah.
Okay. Well, thank you for visiting with us.
Thank you, sir. It's been a delight to meet you.
Thank you.
Mabel is going home, but other patients' journeys are just beginning, as we'll see on the next edition of Cardia in any given week.
For a DVD copy of the program you've just seen, send 1995 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.